This is Stephanie Huff, and I'm recording a concept on self. This one is going to be on feeding and eating disorders. First of all, just an overview. Food is essential for life. Body does require adequate nutrients to meet energy requirements, such as thermoregulation, cellular regulation, and metabolism. Substances that are found in foods are used by the body for growth, maintenance, and repair. Metabolism is a complex process by which the food breaks down and converts food and fluids into energy sources. Feeding and eating disorders disrupt the nutrient supply that stem from biological imbalances, psychological imbalances, and social imbalances. And these disorders can cause either overnutrition or undernutrition. And we'll be talking about anorexia nervosa, bulimia nervosa, and binge eating disorders. Looking at the pathophysiology, there are multiple causes of eating disorders. Feeding and eating disorders are not defined by body weight and external appearance, but by physiological states that give rise to inadequate nutrition. It is believed that family, social context, and cultural provide triggers but that hormones, brain chemicals, genetic causes the individuals to push themselves to starvation or obesity. Looking at your etiology, some biological theories. Genetic and neurologic factors play a role in origination of feeding and eating disorders. Neurologic factors include neurotransmitter function. If they have low levels of neurotransmitters, then they will have an increased consumption of food. Whereas if they have high levels of neurotransmitters, then they have a decreased food intake. Endorphin levels also affect food intake and mood. Low levels of endorphins significantly make the patient underweight. When endorphin levels return to normal, so does the patient's weight. Some of your cognitive behavioral theories. Have been seen with feeding and eating disorders as learned patterns based on irrational thoughts and belief. They also think that thought patterns give rise to destructive behavior, so irrational thoughts lead to feeding and eating disorders. Some of your psychoanalytic theory considers feeding and eating disorders as signs of unconscious conflicts in the individual's mind. There's no reference to biological and cultural factors in this theory. Researchers favor other theories that question this theory. Risk factors. Genetic research deals with behavioral, neurobiological, and temperamental variables. Behavioral is looked at as perfectionism, orderliness. They have low tolerance for unfamiliar situations, usually have low self-esteem and high anxiety. There are some genetic underpinnings, so there's think that genetics does play a role in the development of these disorders. Your sociocultural factors, they portray, the media does portray trim bodies as the ideal. Females are usually hardest hit by cultural influences for the thin body. Age, teens and 20s, are usually targeted by magazines, and those are the ages that they're really getting to when they're targeting these thin bodies. Dieting to control weight in magazines. There's all kinds of different things to help people do weight loss or control their weight or exercise. Male incidences are rising. The use of anabolic steroids has begun to be a problem because they're always looking at these muscle-bound figures in the media. And so that's the body that they're portraying that men should have. Other risk factors, your family factors. Family can be an enabler of the disorder and not the cause. They place emphasis on achievement and performance to be successful. You need to be fit for success. So the parents are, pushing these fit kind of bodies and high achievement and performances. May be survivors of childhood and or adolescent abuse. This does include sexual abuse. After the diagnosis of feeding and eating disorders, they may become enmeshed in unhealthy ways, usually more dependent. Autonomy is decreased. Family members become less stable. Parents are usually overprotective, and food can take an extreme importance in their lives. Other family factors, family systems of interpersonal relations. Families may also have difficulty with conflict resolution. And in the families of the client with eating disorder, they are achievement and performance oriented, which tends to lead the child to an obsession in trying to be that perfect child with high achievement and performance and having that fit body. Prevention, reduce negative risk factors like body dissatisfaction, depression, and basing self-esteem on appearance. They need to increase protective factors like basing self-esteem on body appearance is not a good thing. Replacing unhealthy dieting with appreciation of the body's natural functionality. Everybody has different shapes and sizes normally. Looking at universal prevention, this is aimed at the general public to promote healthy development and understanding issues that can cause these disorders to stop it before it starts. Targeted prevention educates individuals who are beginning to show symptoms. The goal is to provide enough information to stop the eating disorder before it develops. Alright, so looking at clinical manifestations, there are some similarities among the disorders. They all have body image disturbance, anxiety, and ineffective coping skills. So looking at anorexia nervosa, this is a potentially life-threatening disorder. Compels the individual to lose more weight than is healthy for their age and height. They have intense phobia of gaining weight, even when they are severely underweight. They will engage in dieting and exercising to the point of dangerous malnutrition to avoid gaining weight. This usually begins in the teen years. It is more common in females. It is also more prevalent in white females with a history of high academic achievement. They usually have goal-oriented families and develop rigid rules to control their weight. And these rituals can be simple, like cutting the food into tiny pieces, so it looks like that they're really eating when they're really not. Or they may have elaborate issues like preparing lavish dinners for family and friends without consuming any of the food themselves. Alright, so anorexia nervosa is categorized by some of the following, and this is also the criteria for diagnosis. They have an intense fear of gaining weight, refusal to maintain a healthy weight, and a distorted body image. In previous years, amenorrhea was a diagnostic criteria, and that's basically the absence of a period for 3 or more months. But it is not diagnostic criteria now because there's other reasons for people to have amenorrhea besides an eating disorder. Other behaviors besides eating very little and exercising a lot are going to be self-induced vomiting, refusing to eat in front of others, using diuretics, laxatives, and diet pills. We already talked about cutting the food into small pieces while pretending to eat. These are just some pictures of basically what their meal would look like, what their bodies may look like, and you can see several of these are actually models, and they are on this very strict regimen about them not gaining weight. Well, all these teens see these girls that are models and they have these bodies and they think that they need to look like that as well. Alright, in anorexia nervosa, the individual will become malnourished, their hair and nails will become brittle, the skin becomes dry and yellow, and they will have lanugo that appears, and that's just fine sort of downy hair that develops on previously hairless parts of their body. They may constantly feel cold. The body loses the ability to retain heat. It can also cause damage to vital organs like the brain, heart, and kidneys. Pulse rate and blood pressure will drop. Irregular heart rhythms can cause heart failure. This has the highest mortality rate of mental illness. And you can see I found an anorexic Barbie. Alright, so that top picture on the left shows the lanugo, and they will all, talked about them being very cold, and a lot of times they will dress in lots of layers in big bulky clothing, and so a lot of times people are not really aware of how skinny that they truly are because they pile on all these layers of clothing, sort of to kind of keep warm, but also to kind of cover up their body. And then these are just some of the effects that anorexia can have on the entire body. And so it's a lot more than just the few things that we talked about, because you can see it can cause anemia in the brain. They can't think right. They have some fainting issues. They're at risk for kidney failure and kidney stones. Electrolyte imbalances are common. Alright, so bulimia nervosa. This is a disorder in which they binge on food or have episodes of overeating in which they feel a loss of control. After binging, the individuals will use some type of method to purge the food to avoid weight gain. And that could be from vomiting or the use of laxatives. Binging can also be followed by extreme exercise. Many of the clients that have bulimia nervosa also have anorexia nervosa. For a diagnosis, the individual must demonstrate binge eating in association with unhealthy compensatory behaviors like purging or excessive exercise at least once a week over a 3-month period of time. Binge eating is the rapid consumption of an uncommonly large amount of food in a very short amount of time. Individuals will feel out of control during the episode. Usually it involves junk food and fast food and high calorie foods. First, the feelings are pleasant, but then they quickly become distressing. Binge usually ends when abdominal pain becomes very powerful and the individual is interrupted, or they just run out of food. After binging, they will feel very guilty and they will engage in purging exercises to rid the body of those excess calories. Alright, purging behaviors are frequently dangerous and include a wide variety of activities to remove the food from the body. This could be from self-induced vomiting, enemas, or diuretics. Restricting, dieting, and extreme exercising are also common. Purging becomes a purification ritual and means of regaining self-control, because remember, during the binging process, they are out of control. Bulimia nervosa is frequently undiagnosed because many of the people that have bulimia are of normal weight or overweight. The typical age of onset is late adolescence or early adulthood. The disorder mainly affects females. 90% are females, 10% are male. It occurs in about 3% of the general population. Bulimia is more common than anorexia. Some of your comorbid disorders that go along with bulimia are going to be mood disorders, anxiety disorders, substance abuse, and self-injurious behaviors. Your principal indicators for bulimia include an incessant obsession with food and body weight. Your physical signs of binging and purging: trash produced by large quantities of food, enemas, and laxatives from purging. They will have menstrual irregularities, a depressed mood, may have unexplained stomach pain, sore throats, unexplained damage to their teeth, scarring on the backs of the fingers, swollen cheeks due to damage of the parotid glands from all the vomiting. Purging can also lead to dehydration and changes in electrolytes, especially hypokalemia and hypochloremia, so low potassium, low chloride. They will also have metabolic alkalosis can result. Alright, so this is looking at damage of the teeth, because of all the acid, it will break down the enamel, and so they will usually have lots of dental caries. And then you can see on the bottom left, they have bilateral parotid gland enlargement, so they have those kind of thick, puffy cheeks, and that's from all the vomiting. A lot of times they will have ruptured blood vessels in their eyes from excessive vomiting. The picture on the right is actually a ruptured esophagus, which is a rare finding in bulimia, but it is a possibility. Alright, and so these are the calluses that you will see on the knuckles, and that's from sticking their hands down their throat and they're hitting the teeth. And so at first it causes sores and may have some cuts on their fingers, on their knuckles, and then eventually it will turn into calluses. It's also known as a Russell sign. Alright, so these are some of your complications for bulimia, and you can see how they can affect electrolytes, respiratory, cardiovascular, neuroendocrine, and the GI tract. So you see esophagitis is big on there, gastric dilation and rupture related to the force of regurgitation. And then you see the esophageal rupture. It's also known as a Mallory-Wise tear. related to forceful regurgitation as well. All right, and so this is just some of the common findings that you will see on how bulimia does affect the body. So these are just some of your signs and symptoms that you will see. All right, so on your binge eating disorders, they will experience periods of rapid overeating with the inability to stop. And so they will continue to eat long after they are full, may be embarrassed about their behavior. Some can produce a sense of relief or fulfillment with binging, but this gives way to feelings of disgust, guilt, worthlessness, and depression. In binge eating disorders, they have an absence of purging, so they do not try to rid their body of the food. They have a sense of loss of control. Usually they have a sense of embarrassment and disgust after eating. Some of your complications of binge eating disorder are going to be obesity, increased cholesterol, type 2 diabetes, and heart disease. So these are the individuals that are overweight. But any of these eating disorders, usually they have some kind of lack of control in their life. And so a lot of times this is one of the things that they can control somewhat, even though they have periods of loss of control during it. But that's because their mind doesn't work like everybody else's as far as that goes. All right, so some of your lifespan and cultural considerations. Eating disorder symptoms are common in older adults. It's often thought of conditions limited to affecting adolescents and teen populations, but not so much anymore. It is detrimental to individuals at all ages. Use of diet pills, excessive exercise, diuretics, laxatives, and vomiting all occur. Collaboration, lab testing, and consultation with medical professional is going to be needed. You want to help reestablish adequate nutrition and stop the binge and purge behavior. Treatment will include counseling, medication, and even hospitalization in extreme cases. Some of your diagnostic tests for anorexia. They're going to be getting some lab tests. They'll be looking at albumin, which is your protein, total protein, electrolyte levels, CBC, bone density to check for osteoporosis, ECG, because remember they do have electrolyte imbalances and so that can affect their heart, a urinalysis, kidney, thyroid, and liver function test. All of these lab work are done to determine if there's a severe deficiency of any of the nutrients or wasting of the body from malnutrition. For bulimia nervosa, they will do a dental assessment and physical exam. Dentist is often the first medical person to identify the signs of bulimia, and that's because of the nature of their teeth and parotid glands and that kind of thing. The physical exam, you will see broken blood vessels in the eyes from vomiting. And remember, we had talked about that before with your eye injuries, and it's a subconjunctival hemorrhage is what it's called. They will also have dry mouth. They will have those pouch-like face on the cheeks, and that's just due to the parotid glands being swollen. Already talked about their teeth. Often they will have rashes and pimples. May see cuts and calluses on their finger joints, and we showed pictures of those in the Russell sign. For your binge eating disorders, a physical exam is done, blood and urine test, as well as a psychological exam. Your pharmacologic therapy for anorexia, the use of antidepressants, antipsychotics, and mood stabilizers. For bulimia, fluoxetine is also known as Prozac, is the only medication that is used. It has been approved by the U.S. Food and Drug Association to treat bulimia. It is known to lessen the binge and purging behaviors. For your binge eating disorders, the use of antidepressants, particularly the fluoxetine, to help reduce those binge eating behaviors. Your non-pharmacologic therapy for anorexia, they will use individual, group, and family-based psychotherapy. And that is to address the psychological reasons for the illness. The Maudsley approach is effective for adolescents. In this approach, the parents of the affected adolescents take responsibility for feeding their child. They also use a combination of medical attention and psychotherapy, and this will produce a more complete recovery for those suffering from anorexia. For your bulimia nervosa and your binge eating disorders, your CBT, which is your cognitive behavioral therapy, is most effective. It helps the individual focus on present problems and how to solve them. Long-term outpatient treatment is going to be needed for any of these eating disorders, and for severe cases, they will do an inpatient therapy. Your complementary and alternative therapy. Some therapies help to reduce anxiety, and these will be the use of chamomile tea, acupuncture, massage, yoga, and biofeedback. And these are shown to improve mood and reduce stress that are associated with feeding and eating disorders. Looking at the nursing process, assessment data is obtained through a review of physiological and psychosocial function, as well as observation for manifestations of the disorder. You want to rule out other illnesses that can cause significant weight loss or gain. Don't just assume that they have a feeding or eating disorder, because people can have extreme weight loss with cancer, hyperthyroidism, and impaired GI function. They can also have weight gain with endocrine disorders and side effects of medications. You want to get a complete physical assessment for the client with anorexia. They will appear emaciated. The skin is dry with lanugo, may see some jaundice, brittle hair and nails, bradycardia, hypotension, cardiac dysrhythmias are common. A physical exam, psychological assessment, lab diagnostics of the client with bulimia. A lot of times they are normal weight or overweight. They may have pitting and enamel erosion in their teeth, multiple dental caries, ruptured eye vessels, may have a hoarse voice from throat irritation from the excessive vomiting, calluses on their knuckles, and then the pouchy cheeks. These are your NANDA diagnoses for eating disorders and feeding disorders. In planning, goals may include that the client will remain free from injury. They will demonstrate manifestations of fluid volume balance. They will have an adequate urinary output. Their vital signs will be normal. They will not have any complaints of lightheadedness or dizziness. They will not engage in purging behaviors. Electrolytes will be in normal levels, and they will actively participate in individual and or group therapy. Implementation. Care of the client with eating disorder is going to be highly complex. Priorities are going to be protecting the client from physiological effects of the eating disorders, identifying and treating the cause of the behavior, promoting wellness through preventing injury, and encouraging health behaviors and thought patterns. In preventing injury, clients are at a constant or near constant risk of injury, and that's because of their such undernutrition and the consequences of that. Eating behaviors or eating patterns and behaviors are beyond the client's control. Behavioral contracts may prove effective, but only early in the disease process and in the treatment. It may be unrealistic if it's early on, just because they don't have as much control over everything. But basically, they're signing these contracts stating that they are not going to be binging and purging and excessive exercise, and that they are going to eat and that kind of thing. They need constant monitoring, supervision may be necessary, and that's to ensure adequate intake and prevent purging. I know a lot of times they will do some outpatient therapy, but they will keep them at some type of outpatient clinic, and they may have to stay there 24/7, for several weeks. And so they are basically monitoring what they eat, and then they monitor them after they eat to make sure that they are not going and vomiting. A lot of times they may even use some like art therapy or writing in a journal, and that way they can get their feelings out that way, and a lot of times that may help as well. Be aware of legal issues of forced care, because in some extreme cases the intake of nutrients and fluids may be medically ordered and administered to patients whose lives are at risk. But you have to, there's sort of that fine line between trying to save somebody and going too far and then causing a lawsuit to happen. Alright, so in promoting a therapeutic relationship, many clients have been secretive about nutritional habits and purging behaviors. So you want to get a good trust between that patient so that you have good open therapeutic relationships, so that they'll feel comfortable about talking to you about these issues. Treatment does require openness about behaviors as well as discussion of sensitive and painful topics. And again, that's that building that trusting relationship with that client. Transition requires courage on the client's part. They need to have an established trust between the client and the healthcare provider. Respect, consistency, and patience are going to be keys in building trust. Some of your expected outcomes may include that the client remains free from injury, their vital signs, electrolytes remain within normal limits. The client will produce a non-concentrated urine, which means that it's not real concentrated and dark because of them being dehydrated. The client denies any lightheadedness. They don't demonstrate any purging behaviors. And the client participates in individual and or group therapy as prescribed. Alright, so this is the end of the feeding and eating disorders. And as always, if you have questions, let me know and I will try to help clarify.